Good afternoon, everybody. Welcome to BRCA Strong Live on Tuesday as we are waiting for our guest speaker, Dr. Anjali Malik, to join us, who's a breast radiologist. So thank you so much for tuning in, and we look forward to having this conversation today on COVID vaccine. Is it safe for women who are at high risk or have had breast cancer? Again, we're speaking about the COVID-19 vaccine related to breast cancer. So thank you for tuning in, and I look forward to this amazing call and learning so much more information on the vaccine as it relates to us, as I'm personally unsure of whether I want to get the vaccine or what's really going to happen. I know a lot of us talk about, should we get it? Is it time? Is it safe? These are all things that are so important. So I'm here today with Dr. Malik, sharing, more information, as there's so much data all over that we tend to look at, but what are the real facts? And, this is part of the reason that we have speakers come on to share the real facts and the truth and the data that's out there on this vaccine, as well as other data for, breast cancer and survivors. Just in general, we need to make sure that we have information at all times. And one thing that I could say we at BRCA Strong are really proud to have is physicians who come on to educate us with real life stories, real life impacts, and knowing your options on the vaccine, knowing your options in breast cancer treatment, or knowing your options when you're BRCA positive or carry a genetic mutation.
Hello.
Good morning. How are you?
Doing well. How are you? Thank you
I'm
for having me.
You're welcome. Thank you so much for joining. So I was just telling the ladies what we're going to talk about. What I'll do is I'll do a short introduction to myself, and then I'll pass the mic over to you. So
Good.
good morning, everybody. I'm Tracy, the founder of BRCA Strong, where we alleviate the emotional and financial burdens of women facing breast and ovarian cancer, regardless of predisposition, through advocacy, direct assistance, empowerment, and events. And 2021 has been an amazing thing for BRCA Strong, and we are proud to announce we now offer pre-mastectomy care packages to women who are just diagnosed, who women are going in for a mastectomy, and we're here to support you not only with education, but support from other women who are going through similar situations. And today we have a guest speaker, Dr. Malik, and coming in to share and talk more about the COVID vaccine with breast cancer and genetic mutations, and is it safe? As prior to you coming on, I was saying, all of us look all around for different information, but really knowing the true facts and having physicians like you who are so dedicated to coming on and educating us is so imperative. So I really thank you for coming on and dedicating this time to encourage women and share really what is going on out there, and maybe alleviate some of the fears that women are definitely facing.
Thank you for having me. Yeah, no, it's, breast cancer is always at the forefront of my mind as a breast imaging radiologist, and then with COVID, that's everyone's mind. And, as the vaccine rollout continues, I know it's just women and men just have questions about what's safe, what makes sense. And so really important to just get that information out there.
Perfect. Well, maybe you just want to start with a little bit of a short background. And then for those of you who are not following her, you can follow us from our page. And at the end of the chat, I will tag you again, just so everybody can follow your pages. Your videos are so helpful in so many different aspects. And, we talk about mammograms and screenings and like what we should do, and just a place to go to alleviate that stress or fear factor. I really found it so helpful. Your videos are so amazing, and really, again, thank you so much for taking the time.
Yeah, no, thank you so much. So my background, I am a board certified trained breast imaging radiologist. I practice here in DC. I detect and diagnose breast cancer through interpretation of mammograms, ultrasounds, MRIs, and I perform image-guided biopsies using all those technologies and modalities as well. So again, I detect and diagnose. I also am really active on social media, my platforms to help educate and empower on breast health, sustainability, and plant-based living. And so just really excited to be able to touch on this really important topic.
The first question is are the COVID vaccines safe for women who are at high risk or who had breast cancer?
Absolutely. So there are only a couple of contraindications to the COVID vaccine. Really, they revolve around prior allergies and like major like anaphylaxis, like losing the ability to breathe, type reactions to vaccines. So, in terms of prior history of breast cancer, current history of breast cancer, and mutation carriers and other women and men who are high risk, that is not a reason to avoid the COVID vaccine. So it is safe and effective, and even again, if you're undergoing chemotherapy, that would be something that you might want to talk to your oncologist about. And any of these conversations, right? This is just, we're providing information, but at the end of the day, you want to be having these conversations with your doctor about what's safe, what's appropriate, and what's right for you. But the COVID vaccine is considered safe for the most part for high risk women and women with a history of breast cancer. It would be other underlying factors, again related to allergies, that would be the bigger problem. It is also safe for pregnant and breastfeeding women. The initial studies were not performed utilizing women from those subgroups, which of course is problematic, but also somewhat understandable. It's not understandable when you're a woman in one of those two groups. You can see how the way that the pandemic hit, how that they might have been left out of those studies. But we since have had a lot of women registering to be followed ever since the vaccine rollout in December, and multiple pregnant and breastfeeding women around the world have received the vaccine, and it's been safe.
And has it been proven in different ethnicities? Like, has it been studied in all different populations? Just out of curiosity.
Yeah, that's a great question, and I'm not as well versed in some of the nuances of the vaccines themselves. But to my
Okay.
understanding, the efficacy is across the board, because it's not some of those mRNA.
Hmm.
We're not necessarily different on that cellular of a level. We
Okay.
do have differences in ethnicities in many ways, but that isn't necessarily one of them. And then what would be another question, though, is of course the variants, and that data continues to evolve with like the South African variant and the Brazilian.
Right.
But yeah.
And what's the concern with the COVID vaccine in breast? We see a lot of different information on like your lymph nodes get swollen, and then I know women who are going for mammograms or for screening. Maybe you could share some of that information for insight.
No, absolutely. So this has been a really hot button issue for the last couple of months. So basically, when we do a mammogram, we see not just the breast tissue, but also the underarm tissue. That too, when you fall in the mammogram and let your arm hang over, what we call the lateral oblique, we are visualizing some of the axillary or underarm tissue. And that's purposeful. We want to see that tissue because there is some breast tissue that extends into that region normally for many women, but also the breasts drain their fluid to the underarm. So we know we have lymph nodes. Lymph nodes are the normal structures that drain the fluid in our body. We have them everywhere, head to toe. They are normal structures. But in draining that fluid, they can become enlarged, inflamed, or abnormal in response to infection, inflammation, and or cancer. So think of the nodes that your doctor will feel for if you have like a cough, cold type thing, or even you can feel them sometimes get enlarged. Those are the same kinds of lymph nodes that we're talking about. And the reason that we look at the ones under the arm is because for many women who develop breast cancer, if it has spread to the lymph nodes, the underarm lymph nodes are the first ones most often that we're going to see. So with that background, with that knowledge, we have been seeing in women who get the COVID vaccine that same side, so whatever side they get the vaccine in, whatever arm, that same underarm can, not always, but can have some enlargement of the lymph nodes. Now that in and of itself is not a big deal. It's the same as you have a cold, you have some swollen lymph nodes. No big deal, not a surprise to anybody, and we know they're going to resolve. The question is when a woman comes in for her mammogram. And at first, we had no other history, right? At first, women were going and getting their COVID vaccine and then getting their mammogram, and we were
Right.
seeing large lymph nodes. And then come to find out when you start teasing it out and they come back for, they've been called back and they get the ultrasounds, come to find out it was because they had just gotten their COVID vaccine.
Right.
And so that was, creating a lot of problems. We've since been able to tease out what we think makes the most sense for women. So the Society of Breast Imaging released guidelines that said if it does not create significant delays, it is most appropriate for women to try to schedule a screening or a routine diagnostic mammogram when it is 2 weeks before the first dose or 4 to 6 weeks after the second dose. Now, that is, again, for asymptomatic women. So for women who are just getting a screening mammogram or a routine diagnostic, like they're high risk, but they have no symptoms. And if it doesn't cause significant delays. We know that as the rollout continues, some people are getting a phone call like, hey, you can get the vaccine tomorrow. It's hard to plan around these types of things. But for women who have that as an option available to them, they know they need their mammogram in the next few months, maybe try to put it at that, if your mammogram is due in May, maybe schedule it for May 20th instead of May 1st, and that might allow a little bit of extra time for you to have gotten the vaccine by then.
So many women are putting off their screenings, right? And diagnoses are being caught later on. What do you think about like women going in, like and delaying their screenings? And I know, like I said, we've definitely seen a rise. Women are getting caught later. It's not being caught earlier, but like we get the question all the time is, do you think it's safe for me to go for my MRI? Do you think it's safe for me to go for my mammo or ultrasound? And, I respond to them, yes, your centers are cleaner now probably than they ever were in any center.
Absolutely.
But, maybe from your standpoint, we can elaborate a little bit on like why we shouldn't put off screenings and what's really happening.
Yeah, sort of touched on the key points that, through the course of this pandemic, we've seen a lot of delayed diagnosis, a lot of delayed imaging, delayed diagnosis, delayed treatment. And of course, we know that has, less ideal outcomes. So early detection, stage 0, stage 1, go on to have 100% 5-year survivability versus our later stages are 4. And so, my goal is getting women in for those annual mammograms. That year interval is just the time we've been able to establish that, cancers are most often caught early if they are slow growing. 100% places are safe. They're social distancing, they're sanitizing. Everyone is, of course, PPE, masks, etc. And most healthcare workers, not all, most healthcare workers in facilities around the country have received the vaccine. So they are, we still don't know exactly whether the vaccinated people can transmit the disease. But the hope is, of course, that if they're not going to be able to get a severe infection with a high viral load, then they therefore won't be able to transmit the infection. And so, again, there are, when it comes to COVID related, virtually no reasons now not to be getting any kind of health needs. But, of course, for us, it's the mammograms and the MRIs that we're talking about, because it is 100% safe, and we want to be able to get women in for that early detection.
So, I have a silly question. So I have not personally got vaccinated. I haven't got vaccinated, and I'm going to say, like, and maybe from a physician standpoint, this was like my make or break why I was going to get vaccinated, right? Being in the medical profession and knowing like science and clinical data and all this information that we gather, it's kind of scary to me is there's only like a year data on it, like the long-term effects. Like, I don't really go out in public. I don't, like I'm very isolated with my kids and my family, like to the store, home, wash your hands, sanitize, wipe everything down. But like, what do you suggest to women? Because I know I'm not the only one, like why we should go get vaccinated. Like, what is your as like a physician and you getting vaccinated yourself, right? Like, is it just to stop the spread and hope that, things get better in our community, or is it really going to help us from what's going to happen? Obviously, but again, like I said, the long-term data is what's really scary to me, and especially like participating in clinical trials myself, being diagnosed, 18 years ago and seeing the transition of where therapies have gone, but yet they made this vaccine, but yet they can't make a vaccine to have, help the genetic part of, like the kids that have it, like God forbid my child has, BRCA. Like, so to me, it's interesting.
Yeah, so they're actually working on that. Number one, they're starting to collect data and hopefully be able to make it available to children soon. In terms of your question, though, is the vaccine safe? We have long-term data. So a couple of things. Number one, COVID is not safe. Infection, for example, pregnant women were worried about getting the vaccine, but pregnant women getting COVID have a higher rate of hospitalization, a higher rate of severe disease. They've had preterm labor, which then can lead to severe complications and even, of course, loss of pregnancy or their newborn baby. And so, just that is one example. The COVID vaccine hasn't had those same kinds of complications, and it's decreasing the risk for and virtually eliminating the risk for severe disease and hospitalization. So, when it comes to, do I think the vaccine is safe and should people be getting it? Absolutely. You can't stay in your bubble forever. It's just not possible. Number one, I mean, it's not good for our mental health, physical health. It's not good for, it's not good for anything. And we can't stay in our bubbles. Like, you're going to need your mammogram, or, someone's going to need something. And so I understand the anxiety, and that's why physicians like myself and so many others, I am not by any means an infectious disease and immunology expert. And so I don't talk about the vaccine at length because that's not my area of expertise. So I'm here today to talk about, COVID vaccine and the breast. That said, as a physician, as a person who's been living in fear of this virus for, a year now, I think the vaccine is 100% safe. And in regards to, its effects on mammograms, it is not affecting the breasts. It's affecting our interpretation of the mammogram, which is what we want women to know. That if they they are asymptomatic and they are due for both the vaccine and their mammogram, and it is available to them, delaying or scheduling the two in concert could eliminate any questions about the lymph nodes that might be enlarged. Now, there are, so a couple of things happen, right? So you aren't able to schedule the two around each other. You come in for your mammogram, you've just had dose 1 or dose 2 or, whatever. And what do we do? Ways. Number one, now that we've been seeing this for, 2 to 3 months, there are physicians around the world who are comfortable saying there are enlarged, right axillary lymph nodes on the side the patient has reported to have received the COVID vaccine. These are normal post-reactive or inflammatory lymph turn, do that's one route. Just like, fine, go about your business, let's go home. And that's probably fine for majority of women. But the reason that I'm having this conversation with you is, I think about those high risk women who are going to have questions about, I have these abnormal lymph nodes, I have this high risk, is it really okay? And that's why those women, I would just like to eliminate that fear on all ends, right? Like, my goal is to bring awareness, education, and empowerment, and eliminate anxiety when it comes to all health matters. And this is just one more step. So if we just try to do the things, in that appropriate order, we could eliminate all of this anxiety altogether. Another thing, and then the other option is that the doctor say, even though the patient has had the COVID vaccine on this side, and I see lymph nodes on that same side, and even though they're probably related to the vaccine, some women will be called back, they'll get an ultrasound, and they'll probably be followed 2 to 3 months after that. Which again, it's just anxiety provoking.
Right.
We know it is, and so we like to try to possible. So another thing that I want women to know, so I know predominantly your followers are mutation carriers, previvors, but for women who have had a diagnosis of breast cancer, it is, I think, super important and helpful to have your vaccine on the other side. So if you had a right breast cancer, seeing those enlarged right lymph nodes, I think it's just going to be too confusing and anxiety provoking. And so I think just make it easy, make it simple, get that vaccine in the opposite arm. I know that's not available to everyone for whatever reason, but if it is, get it in the opposite.
Is there one vaccine that's better than the other for previvors and survivors, or are they all equal?
Great question. The best vaccine is the one that you're offered first. So, Pfizer, Moderna, Johnson & Johnson, if any others go on to be improved. If someone is listening from Russia and they're getting Sputnik, I don't know, whatever, right. Whatever is on the table, the best vaccine for you is the one that's offered to you first. And so, I've seen people be offered 2 different kinds of vaccines in 1 week, and they'll choose one over the other. And, they can make those decisions, and that's fine. But if you offered me all 3 at the same time, I'd honestly just pick one blindly, because they are, the data is very similar on all the efficacy. And again, the goal is just to get everybody vaccinated. So,
we talk about our survivors, right? A lot of them are also questioning, the lymph nodes, again, is it really safe for them? And is there any side effects more, obviously going on radiation? Is there anything that they should worry about more than they did before? Because, obviously if you're not in treatment, things are a little different, or if you're under surveillance and you're getting screenings, is there anything that these women can eliminate thinking about that you could share?
In regards to the vaccine, or just in regards to
into the vaccine, especially more focused on our survivors, our BRCA mutations, okay, but our actual breast cancer women who are battling it right now, who are going in for treatments. I see a lot of conversations in our group about it.
Right. And so that's the thing that I think it's really important to have that conversation in concert with your oncologist. They're going to know where you are in terms of levels of immunosuppression, right? Because obviously the chemotherapy some kinds are going to be causing decreased immunity, decreased immune response. And so it's a great conversation to have in them. But as an example, one of the questions that they ask when you're scheduling your vaccine, they'll ask, have you had any allergies to XYZ? Have you, do you have any, are you pregnant? They'll ask you if you're pregnant or breastfeeding. Not because they're, saying, okay, you can't get it. What they're saying is, are you aware that there's no data, but that it's been safe so far, et cetera. And another question that they'll ask is, are you on any immunosuppressant medications? And part of why they ask that is because, so I said that my colleague, actually, Islamiat Agosala, said, if you have breast cancer, get the COVID vaccine in the opposite arm, which we talked about earlier. And so, again, because chemotherapy can depress your immunity or suppress your immunity, and because people who have suppressed immunity might not mount the same response to the vaccine, that doesn't necessarily mean it's not safe. It just might not be as effective. For people who are on long-term, lifelong medications, that's just something they have to know. But again, it could be a conversation with an oncologist that's like, hey, I'm on my 6th chemo round. Should I wait? Should I not wait? I don't want to make those decisions. We're not here to make decisions today. Those are conversations that you want to be having with your oncologist and your breast care team.
Definitely. Are there any different guidelines for breast screenings in light of our pandemic? Has anything changed? Are the guidelines still the same? No?
No, so for Society of Breast Imaging and American College of Radiology, it's annual every year starting at 40 for average risk women. So your average risk women are your 1 in 8, no strong family history, no premenopausal family history, and of course not gene mutation carriers. High risk screening applies for whatever tailored screening protocol has been established for, whether it's a mutation carrier, whether it's a premenopausal breast cancer, et cetera. All of that still applies. And again, it's, centers are ready and waiting to take care of patients. One thing about breast cancer screening guidelines, though, is that, the United States Preventative Task Force, the USPSTF, in 2009 released really controversial guidelines that have since had women and providers confused, as well as the American Cancer Society in 2015. Those guidelines both have some variation of every other year and start at this age and start at that age and stop at that age and all sorts of crazy, confusing things. However, the data shows that annual mammography starting at 40 has a 40% mortality reduction for average risk women. We save the most life years for women in their 40s, and 1 in 6 breast cancers is diagnosed in a woman in her 40s. So the start time, I have no question in my mind if you're average risk annually starting at 40. There's also been a couple of things recently that have happened. Number one, the USPSTF and the American Cancer Society both acknowledged they did not take the latest data regarding newest technologies into account when they made their guidelines. So many of you have heard of 3D mammography or tomosynthesis. That's widely used now. My center does 100% tomosynthesis for our screening mammograms. Back when those other guidelines, USPSTF and ACS guidelines were made, they did not take that data into account. So they were making their decisions on 2D analog, so like old school film that you hold up to the light. Is that anymore? That's literally just for TV now.
Right.
On Scrubs with the upside down. It's like upside down and backwards, all sorts of wrong. No one's doing that anymore. I mean, I'm looking at a screen, I'm looking at digital, 3D, just, absolute best technology. And I'm detecting and diagnosing breast cancers that, of course, they were probably missing on those old school technologies. It was completely, right. It's night and day. I mean, your apples, oranges, whatever metaphor you choose to use, that's what it was. And also, it's just a different time. Radiologists weren't specialized in breast imaging, universal, things like that. And then a couple of other things. There have been 2 papers that have come out recently. One showed that women who do not have consecutive mammograms, so meaning like year after year, so if they had one in 2017 and then a cancer was found in 2019, they don't have as good of outcomes. Which again goes along with the early detection. And number 2 is that breast cancer has overtaken lung cancer as the most common cancer. And that's for a variety of reasons. We know that hormones are a large cause for breast cancers, and not just hormones that we take, but hormones that we have. Our top 2 risk factors for breast cancer, for the development of breast cancer, are being female and aging. Now that's an average risk woman. For mutation carriers, your risk is your mutation, plus being and aging. But all this to say that until we find a way to 100% go in and zap out, whatever it is that's causing the cancers, we will always be at risk for breast cancer just by virtue of being a female, whether you are a cisgender female, a transgender female, a transgender male. Once you have had the estrogen in your body to make you a female, or to previously have made you a female, you are at risk for breast cancer. And so, it's just annual mammography is just going to be the staple. And then the other thing I'd like to talk about when it comes to breast cancer and any type of cancer is that cancer, we have this really negative relationship with it in our society. Understandably, it causes a lot of heartache, a lot of loss of life, a lot of decreased quality of life. But cancer is a side effect of living. And in Russia, there's a phrase that a Russian patient told me once. She said, "We say, may you live long enough to get cancer." Meaning, if you're alive long enough, that assembly belt that's making all the cells in your body, it's gonna have an I Love Lucy moment. It's gonna have a moment where Ethel and Lucy are making their chocolates, and the starts going too fast, and they just start eating the chocolates and putting the chocolates in their pocket, which is not what they were supposed to do. So as much as we don't want to develop cancer, and we try to prevent cancer, and we try to reduce our risk, and we try to do all the right things and screen for it, etc., just know, do what we can do our best, get our screenings, take care of ourselves, and then, hit the cancer road when and if we have to.
You talk about screenings. Maybe you could explain the difference to why, like, you'd have a regular mammogram versus a 3D mammogram. Like, I know the quality, but a lot of women, insurances don't cover it, or they don't have insurance, so they just get a mammogram. But the difference between them, and the quality and all the background from a physician.
Sure. So a 2D mammogram is a standard X-ray. So the same way as you would, get the X-ray of your chest, or get or X-ray of your foot, something like that. A 2D mammogram is basically that. It is, two views of the breast from each direction, and it is really limited by tissue overlap. So on a mammogram, our tissue is white, our fat is black, and cancer shows up as white. So for women who have a lot of breast tissue, cancers can hide inside that. And reading a 2D mammogram is like reading a closed book. So then we created 3D mammography. And 3D has the benefit of, instead of just being a closed book, you're actually opening that book and looking at the pages. So it becomes a flip book of the breast. So obviously you can read the words on each page versus you can't when it's a closed book. And so it just is a much more detailed, accurate view of the breast. It's improved detection of small invasive cancers. It's decreased false positive callbacks. And so, that's just the ideal, the best of both worlds.
Right.
Better for the evaluation of women with dense breast tissue. What does dense breast tissue mean? Well, like I said, you have tissue and you have fat in the breast. Dense breast tissue is not a thing. It's not a thing like blue eyes or brown eyes, black hair or brown hair. It is a proportion. So it is the proportion of tissue to fat that you have inside the breast. So some women have more fat. That's not an assessment on them. That's not something to be ashamed of. It's not like a body shaming thing. It's just who they are. Constitutionally, inside their breasts, they have more fat. On the flip side, some women have way more and or no fat. They have way more tissue and no fat, or different proportions. We have 4 categories that we rank it in by the American College of Radiology. So for women who have dense and extremely dense, which are categories 3 and 4, they are, 1, at higher risk for the development of breast cancer, and 2, there's decreased sensitivity on the interpretation of their mammogram, because again, those small cancers could hide inside that tissue. 3D mammography did help decrease some of that. With 3D mammography, there are some women who would benefit from additional screening, that the ultrasound or MRI. So if an average mammogram detects between 5 and 9 breast cancers per 1,000 screening mammograms, ultrasound will add an additional 3 per 1,000, and MRI will add an additional 15.2 to 15.5 per 1,000. So, you can see the additional benefit. That's not to say that mammography isn't good. Mammography is the tool for screening the whole population. It's cheap, it's effective, it's easily accessible, it's easy to do, and it's easy to interpret, and it's overall low risk. The amount of radiation that we get in a mammogram is safe. It's within the FDA limits. There are no negative effects, deleterious effects from the radiation in a mammogram. It's similar to the radiation you would get flying to Paris, and I don't think anyone would say no to a trip to Paris. I would fly literally anywhere at this point. So,
You're ready to go.
So that's some background on that. And then you asked one other question. You said, talk about mammography. Oh goodness. You said something in your last question that I'm sure will occur to me later, about something what I wanted to say, but that's okay. So, I mean, but you know, again, that's why, oh, the coverage for 3D mammography. So a couple of things with that. When 3D mammography first came out, a lot of insurance companies were not providing coverage. Most major insurance providers now provide coverage for 3D mammography. In addition, several states have mandated coverage, such as New York, Texas, and we continue to lobby. We as breast imagers and, you know, getting in contact with our state legislators. In fact, a fellow breast imaging radiologist was recently able to help pass legislation in Missouri, I believe. So again, we're always making these efforts in the same way that we did for breast density reporting. So previously women did not know about their breast density. They did not know that they were at increased risk or that their mammogram might not be, you know, as sensitive. And so breast density reporting laws have been being passed around the country and are almost, you know, almost universal at this point since the early 2000s. And so I'm in the DC area. We don't see a lot of 2D mammography anymore. Most insurers are covering it at this point. If you are a woman who finds yourself in a situation where the 3D mammography is not covered, you know, I mean, I'm all about advocacy. I would contact your state legislators and let them know why that is putting your health at risk. You know, women's health needs to be an important part of the conversation. I'm not going to get into the details of, like, you know, men get this covered and this gets covered and that doesn't.
Oh, we could definitely go there. That's a whole nother conversation.
Yeah. But exactly. So, you know.
But getting your state legislators really involved, you know, can help as well. And,
Absolutely.
you know, making a difference. You know, women can't afford mammograms, right? There's free mammograms out there. There's tools for MRIs that can get you approved. And, you know, for our listeners out there, you know, if you're not getting a mammogram or if you or your family know that they can't afford a mammogram, reach out to us. There's definitely foundations that can get you screened, genetic testing. You know, in general, we want our numbers to lessen. Like, I know the state of Florida has a 30% of women are not having mammograms. Like, that's crazy to me. Like, there's funding out there, there's missions out there, you know, there's mammogram events. They're $100. You can't afford it, come find an event. You know, we'll make sure those screenings are happening because we need our numbers to decrease. You know, as I tell everybody, is one of my quotes is, you know, breast cancer does not quarantine, doesn't quarantine, it's still coming.
Yeah, exactly. No, exactly. And agreed. You know, we understand the financial constraints. So if you have any kind of insurance, it covers screening mammograms. It might just cover 2D, but it covers screening mammograms. And also, like you said, there are so many resources out there to ensure that women are getting the care that they need. And so, you know, I would 100% encourage women who find themselves in that situation to, you know, to try to reach out and find those resources. But I am going to have to get back to seeing patients soon. So do you think there are any lingering questions out there?
There was one question somebody asked. Have you passed the COVID of doctors and have you been vaccinated? I don't know what that is, but we could skip that one.
Yeah, so I mean, most healthcare workers, if they choose, have been vaccinated at this point. I have been vaccinated, as have you know, colleagues, and we're just so thrilled to have, you know, to be in this place. I mean, a year out, you know, to now feel like we're getting more protected and being able to protect our patients and offer the services and get back to 100%. You know, we've still up until this point had not lighter schedule, but we had to restrict some appointments because we wanted to allow for waiting rooms to have more space and for that sanitizing and things like that. So, you know, we want to be able to offer as many women the care that they need.
Perfect. Well, I really appreciate you coming on and taking the time and dedication out of your day. I know you're super busy performing stuff and helping women. So I really appreciate your time and look forward to having you back on in the future. And for those of you that don't follow Dr. Malik, go on our page and we will post this video and you could share with your family and friends and educate the community, because that's what we want to try to do, is bring as much awareness as we can. So thank you again for your time.
Thank you so much, Tracy.
Have a great day.
Bye.
Bye-bye.